Hello and good afternoon, everyone, and welcome to today's webinar session, Antigen Testing, Championing a Future of Better Patient Outcomes in Urgent Care. This webinar is being sponsored by BD in collaboration with the Urgent Care Association. My name is Joseph Mann, and I am a medical science liaison currently working in point-of-care diagnostic solutions at BD. I will be moderating today's session, and with that responsibility, I have the sincere privilege of introducing today's speaker. With me here today is Dr. Amesh Adalja, who's a senior scholar at the Johns Hopkins Center for Health Security, an adjunct assistant professor at the Johns Hopkins Bloomberg School of Public Health, and an affiliate of the Johns Hopkins Center for Global Health. Dr. Adalja's work is focused on emerging infectious disease, pandemic preparedness, and biosecurity. He is a native of Butler, Pennsylvania, and actively practices infectious disease, critical care, and emergency medicine in the Pittsburgh metropolitan area. Today, Dr. Adalja will be reviewing and discussing the value of performing respiratory testing at the point of care and how having access to low-cost, easy-to-use rapid antigen tests can help increase provider diagnostic confidence and better ensure that patients presenting with upper respiratory symptoms are receiving appropriate treatment. Also, before I turn it over to Dr. Adalja, if you have any questions at any point during his presentation, please type it out into the chat box, and we will do our best to ensure all audience questions are answered in a brief Q&A session at the end. And with that, I'll hand things over to Dr. Adalja so he can get started.
Thank you for that introduction, and thank you for signing up for this webinar. Like you heard, I have multiple different roles. I'm primarily at a think tank that's focused on infectious disease emergencies and policies. And as part of that, diagnostic testing is one area that I really champion and really try to study and advocate for it. And you're going to kind of see that percolate through this slide deck. The other thing is that I actively practice emergency medicine, critical care, and infectious disease in the Pittsburgh area. So I'm not just going to pontificate on the policy. I'm actually someone that actually orders these tests and thinks about these tests. My Twitter address is on that first slide if you're interested in following me, because I talk a lot about infectious disease. So with that, I'm going to speak for probably about 47 or so more minutes and then give you 10 minutes of Q&A. And I really enjoy Q&A and getting asked hard questions if you have any. So next slide. Next slide.
It's not working.
Oh, there we go.
So I'm going to go through a few different things. First, I'm going to talk about kind of at a very 20,000 foot level, why you want to get a diagnosis, how that helps you, especially when you're thinking about an urgent care setting when it may not change your treatment. I'm going to talk about a concept that I kind of coined called biological dark matter and explain why it's important to really know what's making people sick. I'm going to also talk about antibiotic resistance. I know I'm speaking to an urgent care audience. There is a lot of antibiotic prescribing that goes on, or at least a lot of antibiotic demanding that goes on at urgent care centers. And I'm going to talk about how diagnostic testing helps fight antibiotic resistance, and then talk about integrating point of care diagnostic technology into care. Next slide. A couple of disclaimers from BD. This presentation is on behalf of BD. Any discussion regarding BD products during the presentation is limited to information that is consistent with FDA approvals or clearances, and consult the BDA product labels and inserts. Number two, this is informational only. The opinions and clinical experience I'm going to present are informational only. And number three, I am going to be compensated by BD to give this presentation. Next slide. So a couple of things that I want to really harp on are why you want to diagnose. And I have this word there, Rumpelstiltskin. And people might wonder, well, what does this have to do with Rumpelstiltskin? And do you remember the German folk tale of Rumpelstiltskin? How does that person, how do they get control over him? by figuring out his name. And if you watch the movie The Exorcist or any of those exorcism movies, how do they get control of that demon? By figuring out its name. And that's the paradigm I think about in infectious disease, that once you understand or once you know what's making something sick, whether this is rhinovirus or whether this is RSV or whether this is group A strep or whether this is Ebola or COVID, whatever it is, you gain a lot of power, a lot of knowledge that can then be applied to that patient. You can tell that patient what's going to happen. Are they contagious? What treatments are going to work? What treatments aren't going to work? So I think naming something gives you a lot of power over that illness. And it gives you, and I think it's very satisfying to know what's making your patient sick. Because for many patients that come in, and this is really probably the majority of patients in the urgent care setting, they come in and they've got an upper respiratory infection or a community-acquired pneumonia, and you don't actually know what's making them sick. They've got that disease, and you're going to give them some antibiotics. They may get better. They might not get better. You might refer them to the emergency department. You might ask for some more testing, whatever it might be. I think a lot of times what happens is people get diagnosed as part of a syndrome. You have community-acquired pneumonia. You have an upper respiratory tract infection. You have sepsis. We don't know what caused it. You have meningitis. We don't know what caused it. You have encephalitis. We don't know what caused it. That's not really satisfying. Have you ever heard of that happening in cancer? Where someone says, you've got cancer. We don't know what type it is. We're going to give you something for it. Maybe you'll get better. Maybe you won't. But that's the paradigm in infectious disease testing, is that oftentimes they just don't really get to a specific diagnosis. And that's very different than, if I were giving this talk in the 1920s, people would get pneumonia, they would get a tracheal aspirate, they would figure out not only that they were infected with pneumococcus, but what serotype of the pneumococcus it was by injecting it into mice. That was a very specific diagnosis, and then they would get a specific serum therapy based on which serotype of pneumococcus they had. Broad spectrum antibiotics sort of did away with all of that. But what we gained in not doing tracheal aspirates on people with pneumonia is we gained a lot in terms of patient safety, but we lost a lot of information, and we use broad spectrum antibiotics that really take care of everything. And people think, oh, that's great, but it's not really great because we have no idea what's making people sick. And we have big major gaps in epidemiology, and we don't even know if the antibiotics are helping people, because what's the most common cause of community-acquired pneumonia is rhinovirus, not pneumococcal, not pneumococcus, not mycoplasma, not Climadophila. It's a virus. And so a lot of times you don't need to use antibiotics, but we don't really know what makes people sick. And this is not just in these minor cases that I'm talking about that come into an urgent care center. If you walk through an ICU, I'm talking to you from Pittsburgh. If I walk through one of UPMC's ICU and walk around the critical care doctor and said, what's causing the septic shock in this patient? They'll say, we don't know, cultures came back negative. And about 50% of patients, they don't know what's making people sick. That's not a good paradigm if you want to be resilient to infectious disease threats and you want to put people on the correct treatment. And that's, one of the pushbacks I get is, oh, this doesn't change treatment if you know that this person has metapneumovirus or this person has adenovirus, but it does. You can give them analgesics, you can give them antipyretics, and you don't give them antibiotics. That's changing treatment. You're not giving them something that could be potentially harmful, that will increase antibiotic resistance, that will increase the chance of a drug reaction. And anytime you put these types of tools in doctors' hands, they do change treatment. The other thing is that there are antivirals for influenza, antivirals for COVID that are important to give, or antivirals or antibiotics for group A strep, for example. So there are separate treatment pathways, and a treatment pathway doesn't just mean you have to have a specific drug to give somebody. It could be, I'm not going to give this person a Z-Pak because I know they have a rhinovirus infection, not a bacterial infection that would merit an antibiotic. So there are separate treatment pathways that diagnosis does. And then, I work in a think tank where I think a lot about infectious disease emergencies, and epidemiology is a really important side effect of better diagnosis, because then we know what the patterns of illness are. We know that, oh, there's an RSV surge going on in this town, or there's a lot of metapneumovirus here, or group A strep is increased in this state. And that gives us a baseline that really helps us understand when something is different, when there's a new pattern of illness. You could imagine the early days of COVID, and you're an urgent care center in Wuhan, and you've got a really great diagnostic panel that tests for 8 viruses, and all these people are coming in to an urgent care center, an emergency department. They all have flu-like symptoms, and they're testing negative for all 8 of them. But there's a million of these patients coming in, one after the other. They're all testing negative. Doesn't that give you a hint that maybe something else is going on here? Maybe we need to get more sophisticated testing because they're testing negative on this panel, yet they're all sick. So it can also serve as an early warning when you knit these things together as part of epidemiology. So that's another really important aspect of diagnostic testing that often isn't thought about. But remember, urgent cares are the front line when it comes to many of these emerging infectious diseases that are going to present as respiratory infections. They're going to show up at urgent care centers first. Next slide. So I came up with this concept several years ago called biological dark matter. And that's what I call all these undiagnosed illnesses, all those URIs that you see, all those sore throats, all those pneumonias, all those people that have an infectious syndrome for which we don't get a diagnosis. And it's not because there's not the technology to do it. It's just because people don't do it. And there's lots of disincentives to doing that in terms of economics, in terms of diagnostic stewardship that might happen at a hospital, or because it doesn't change treatment, quote unquote. But we leave all that biological dark matter on the table at our peril because we don't actually know what makes people sick. And then we don't know when something is different. We don't know how long something might have been spreading. COVID-19 was spreading in China probably from November, mixed in with all of the other respiratory viruses. Imagine what a head start would have done. It was spreading in the United States, probably in December, mixed in. Imagine what that head start would have done. So I don't think that this idea of not knowing what makes people sick is a good thing. I think that dark matter needs to be illuminated. And the fact is, we now have diagnostic technology in all different forms that are able to illuminate that biological dark matter and give us much more certainty about what's making people sick. Next slide. So one of the things I like to discuss is kind of why I care so much about respiratory viruses, why this is such an important topic to me. And I spend a lot of time thinking about the philosophy of infectious disease and how it affects humans. And I think it's important to keep in mind that that when humans moved from nomadic tribes to living together amongst each other, that basically was the age of epidemics, the age of pestilence and famine, it's called. And that meant that people were going to start exchanging viruses with each other. And that's what happens when people when people live in close proximity to each other and to their animals. Infectious diseases start to rise. And then the Industrial Revolution with antibiotics, with vaccines, decreased the level of epidemics. But now we have globalization, urbanization, and aging, leading to more infectious disease threats. So this is kind of part of the human condition. And what we can either kind of do the status quo, or we can try and gain mastery over this by using tools that science and medicine give us. And I think many of those tools sit on the table. They aren't used appropriately or effectively to make our lives a lot easier in a world in which infectious diseases dominate. If you were an alien looking at the Earth, you would say, that's a planet of viruses, bacteria, fungi, some parasites, some protozoa, and some other things. So just recognize that infectious diseases are not going to be avoidable, but what we can do is use tools to kind of infectious disease proof ourselves as much as possible, or give us more resiliency or gain mastery over them. Next slide. So as I said, when we went to this stationary transition where people were living in cities, human-to-human interaction increased. We had to deal with waste management, agriculture, lots of things happened, and that's what drove these infectious diseases. And if you think about humans as a species, all of our evolution has really been for nomadic foraging lifestyle, not for urban industrial. So evolution hasn't had time to change our genes to make us more resilient to infectious diseases. We've basically been a nomadic population the entire time that humans have been on Earth. And so this role of infectious diseases is something a little bit new from evolutionary timescales. Next slide. So one of the things that I spend a lot of time thinking about are what causes a pandemic. And you can see a slide there of a report I issued prior to COVID on the characteristics of pandemic pathogens. And I'm kind of putting this stuff in here just to give you a lot more, punch to what I'm saying about diagnostic testing, because it's not just like you're treating the patient. You are just treating the patient in front of you, but there are big implications for being better at infectious disease management. So what can cause a pandemic? These are the criteria that I think will likely be present in a pandemic pathogen. And if you map this onto COVID, it really fit. So efficient transmissibility from human to human. You have to be able to get from person to person. A moderate fatality rate. It doesn't have to be a high fatality rate. What you want are people that are contagious during their incubation period, that are out and about, infecting other people, mild illnesses with contagiousness, affecting an immunologically naive population, which means a population that's never seen something like this, no off-the-shelf vaccine or treatment, and ability to evade the host immune response. So when you get those types of things, you're looking at a pandemic pathogen or a potential pandemic pathogen. So with COVID-19, as soon as efficient transmissibility from human to human was confirmed in China, somewhat delayed, but was confirmed, that was telling you that that was going to be a pandemic pathogen. But the point to bring this back to what we're talking about today, diagnostic testing, mild illnesses with contagiousness, being able to know that someone has something new or different is really important as an early warning for a pandemic. So if you go back to the prior pandemic, the 2009 H1N1 influenza pandemic, the only reason that got picked up in April of 2009 was because the first two children that were diagnosed in California, happened to go to an urgent care center that was part of a research study that was typing all the flu strains, and they realized that this was a novel flu strain that was present. So there is a role for this. I'm not just kind of talking pie in the sky type of stuff. There actually is practical value to knowing what's making people sick. That really has implications for pandemic preparedness. Next slide. So what I really advocate is taking respiratory viruses seriously, not just thinking, oh, you've got some bug, you've got some flu-like illness. And I think I've tried to concretize that just telling someone you've got some virus is not very satisfying, because they might have the first case of a novel coronavirus. Someone had the first case of a novel coronavirus, and it probably was missed. And this biological dark matter is something that you just don't want to, it's just not satisfying. That's basically what I'm coming to. Just tell people you're sick with something. That doesn't satisfy you. It doesn't satisfy the patient, because the patient, they just had to have some virus. It's much better if you tell that patient, oh, you have adenovirus, or you have metapneumovirus, or you have RSV, or whatever it might be, because then they actually know, they can read about it, and they can post it on Facebook if they want. Lots of people like to post what they're sick with and get sympathy from other people. They can do that as well. If they say they've got metapneumovirus, for example, they can then refrain from taking things or not ask for antibiotics if, for example, they know they have a virus. And I think you have to also recognize that there's this spectrum of illness, and knowing catching someone when they're in the milder stage is really important at the later stage. If someone was sick, so I work in an infectious disease setting, someone was at an urgent care center, they were in an emergency department, then they got admitted with pneumonia, and all that time, no one did a diagnostic test. I've had cases like that. Someone came in with a COPD exacerbation, was treated for a COPD exacerbation, came back in basically with pneumonia and hypoxic, and now that person, when they came in for the COPD exacerbation, was not tested for influenza, was not put on Tamiflu, therefore, and then came in outside didn't benefit from Tamiflu and came back in much sicker. So there is this spectrum of illness that I think you need to respect, that getting these diagnoses early before they have, this idea of like, I'm not going to test you for these viruses because you don't look that sick now. That's not a good way to approach respiratory viruses. Next slide. And as I said, specific diagnoses can lead to antiviral therapy. Drugs like Paxlovid, drugs like Molnupiravir, drugs like oseltamivir or Tamiflu or Xofluza are all underutilized. We're not using those tools effectively. When you take care of COVID-19 patients in the hospital that are high risk, they invariably were never prescribed Paxlovid when they first were diagnosed. And it's not hard to prescribe Paxlovid. It's not the drug. I know people are intimidated by the drug-drug interactions, but those are pretty easy to manage. There are guide sheets that the Infectious Disease Society of America has put out. And I think that getting a specific diagnosis and putting people on antiviral therapy goes a long way towards decreasing morbidity and mortality. Remember, a drug like Paxlovid is was 90% effective in preventing hospitalization in unvaccinated individuals. So this is, COVID-19 is becoming a preventable illness in terms of needing hospital level care. Next slide. So this is a really great paper that came that came out several years ago, talking about the fact that when you start doing molecular testing for respiratory pathogens, you start to find interesting things. And this is where I said, everybody thinks community-acquired pneumonia, oh, that has to have antibiotic, that has to be bacterial, when the majority of cases are viruses. So the number one cause, viral pathogen only in 22%. That's should give you some pause that many antibiotic prescriptions for pneumonia aren't really merited because it's all viral. So this is just an important point, that if you actually test, you actually get really actionable, valuable information that you can use to then treat your patients. Next slide. And one of the things that I want to really harp on is antibiotic resistance, because when you don't make specific diagnoses and you just throw antibiotics at people because they're demanding it, or because you're uncertain, or because that's the path of least resistance, I know that people say, well, that avoids a patient complaint, or they're just going to go to another urgent care doctor and get that. I don't think those are really good ways to approach it, because what we're doing is increasing antibiotic resistance, and you can't continually kick the can down the road and say, well, that's not my problem. Pharmaceutical companies will make new antibiotics, but they're not. Pharmaceutical companies that are making new antibiotics are going bankrupt. There are no new antibiotics with new mechanisms of actions. And if you go to an ICU, you will see people with horribly drug-resistant infections. And what's driving that? Inappropriate use of antibiotics. And I think that's, I'm not meaning to blame doctors for all of it. Obviously, farmers use them inappropriately too in farming, because it increases the weight gain and brings pigs to market faster, brings cows to market faster. But this is a major threat. I've taken care of many patients that have totally drug-resistant infections where I just say there's nothing you can do, including a 19-year-old girl with cystic fibrosis. So I think that should give you some pause, that this isn't something that'll happen down the road sometime. But this is happening today, now, in a hospital, in your community. There's probably somebody there with a very resistant drug-resistant bacteria. So specific diagnoses, avoiding antibiotic use has real-world implications today. Countries have been able to reverse MRSA numbers, for example, in the Netherlands, by being aggressive with antibiotic stewardship. So I think that's an important role. And as I said, I also do emergency medicine. I did a double residency in internal and emergency medicine, and then fellowships in infectious disease and critical care. And I still work about 3 shifts a month in the emergency department. And maybe I'm a little different than you, but I welcome complaints for not giving an antibiotic. I love to take that debate on with the quality officer. But maybe you don't like to do that, but I wear it as a badge of honor when someone complains that I didn't give them antibiotics. Next slide. And I think, I always like to put this quote from Alexander Fleming, who was the discoverer of penicillin and won a Nobel Prize, just saying that this was going to happen, that antibiotics are tools. And if we don't use the tools correctly, we will lose those tools. They will stop working, and they have stopped working. And he was right. He was saying this in the 1940s, and that was part of his Nobel Prize speech, just really talking about the fact that it's very easy to create drug resistance. So antibiotics are not something that you can use injudiciously. If you don't use them correctly, we will lose them. And I think that's an important point to continue to make. Next slide. And just to look at the headlines, I mean, I'm harping on this because I think it's one of the important things to keep in mind, is that that these headlines are only increasing over time, that we continue to have all of these bad bugs and no drugs. And we have to actually take this seriously. And diagnostic testing is one pathway, because you get specific diagnoses. You can use narrow spectrum antibiotics if you need to. You can avoid antibiotics in all those viral infections, because people are much more likely to not complain if you tell them they have a virus and you show them on a piece of paper which virus or what their specific diagnosis is. Next slide. So I think that a lot of people would push back and say to me, well, I don't know. I'm only seeing this patient now. I don't want a bad outcome. I'm afraid of getting a bad outcome. I'm afraid of getting a complaint. I'm afraid of getting a lawsuit or missing something. And, you know, I think that lots of people just try and play it safe. And I don't think that's the way to go about it. There are tools like CRP and procalcitonin. They're not always available in a timely manner. Hopefully, they will eventually be things that are available point of care so that people can use them. But I think that this physician discomfort and playing it safe is not the right trade-off. And I think people are kind of privileging the short run for the long run and not saying, you know, like I said, kicking it down the road. And I think that that's something that diagnostic testing can help overcome, that physician discomfort by giving you more comfort, by giving you more tools to get more information about your patient, which then you can use to treat that patient with. Next slide. This is one of my favorite slides, but also one of my least favorite slides because it's horrible. In the 2013 season of flu, so this is after 2009 H1N1, only 15% of PCR-confirmed flu cases got antivirals, but twice as many got an antibiotic agent. I think that's insane. That if they're PCR positive, 15%, only 15 of them are getting an antiviral, but 30% are getting an antibiotic. That makes no sense to me, and that tells me that the fact that this happened after the 2009 pandemic, where antiviral therapy was really instrumental in decreasing the morbidity and mortality, tells us that there's a lot of work that needs to be done. And this is an editorial from Michael Eisen, who's now at NIH, that said that we're failing our patients. So it's not only that, you know, we're doing too much antibiotics, we're doing too little antivirals. And so that's like the worst of both worlds. And that's why I really have taken this kind of as a little bit of a crusade to push people towards diagnostic testing of viral illnesses. Next slide. So even when people are critically ill in the ICU, 50%, only less than 50% are tested for respiratory viruses. So we're just not, people just are not interested in getting this answer. And I think that paradigm has to change. Next slide. So when you think of diagnostic testing, I think you have to think of it as a tool, as a way of empowering the physician, empowering the provider, the APP, the PA, the nurse practitioner, that now gives them new power over this illness. It's that Rumpelstiltskin process. Now you know this is such and such a disease. This is what the treatment pathway is. And it's a tool to better steward antibiotics, and it's also a tool to better steward antivirals. So what it does is an extension of you as a provider to be able to actually help the patient. I try to use everything at hand, especially if they're CLIA waived and can provide rapid results. So I use things like CRP, procalcitonin, rapid point of care strep test, mono test, flu test, RSV test, COVID test, whatever I can use when I'm trying to figure things out. Some people, you know, it might be overkill on some people, but I will always test a respiratory viral person for something, whether it's flu, COVID, RSV at minimum, or if they're getting admitted, then I will test for full viral panels. But I'm also trying to get some understanding of, can I avoid antibiotics? How sick is this patient? And that's why I use things like CRP and procalcitonin as well. The more tests that we have, the better it is. And I'll talk about that in a little bit later. But I think in general, using those tools judiciously and effectively and broadly helps with a lot of downstream issues that happen with infectious disease problems. Next slide. So rapid influenza testing leads to reductions in antibiotic use in hospitalized patients. So this is just a study from Rochester talking about the fact that when you put a rapid diagnostic test in a provider's hand, they will prescribe antivirals more and antibiotics less. So doctors know how to use this information. It's just getting it more use. So anytime you put these tests in people's hands, they're able to do them. And I think this is an advocacy for more broader testing and being able to have that part, you know, as an extension of your stethoscope, that you're testing people for certain viruses and then using that information to influence patient care. Next slide. So this is another study. I'm just kind of really hammering home that these have all been studied. So impact of antibiotic prescription of rapid antigen detection testing in acute pharyngitis. So even though 30% of people with a negative antigen test for strep still got antibiotics, it did still reduce antibiotic prescription rate. So while it's not perfect, while some people still hedge, it does decrease prescriptions of antibiotics for non-strep pharyngitis. And that's, again, just harping on that theme of putting tools in providers' hands decreases antibiotic prescribing, increases correct treatment protocol adherence. Next slide. Again, another one. You're going to get sick of seeing me do this, but I'm going to do it on purpose. So effective rapid viral diagnosis on the management of children hospitalized with lower respiratory tract infection. You can see decrease in length of stay. You can see and duration of IV antibiotic therapy goes down when they actually are identified as having RSV. Just showing again that these things do make differences in patients. Next slide. Even with conjunctivitis, which you probably see in the urgent care center, most conjunctivitis is caused by adenoviruses, and there is a point of care adenovirus test. And lots of people get topical antibiotics for a red eye when they don't merit it because it's actually adenovirus. So there is a point of care test that you could do that this person has adenovirus, which is the most common cause of viral conjunctivitis, and then they refrain from getting eye drops, which most of the time don't work. I mean, they're not going to work anyway, and half of them irritate your eye more than the actual problem you came in with. So even there, it's cost effective in terms of decreasing antibiotic prescriptions for topical ophthalmic antibiotics. Next slide. So this is from the guidelines from IDSA and the Society for Healthcare Epidemiology. And basically what they say is should antibiotic stewardship programs advocate for use of rapid viral testing for respiratory pathogens to reduce? And they do. So this is a recommendation for antibiotic stewardship programs. And while many urgent care centers might be standalone, they still should have an antibiotic stewardship program. And clearly the urgent cares that are part of hospital networks should be covered by the antibiotic stewardship program. But this is something that is a recommendation from the IDSA and SHE, and I think it's not often implemented all the way down. It might be implemented in an emergency department, but not so much, maybe not in an urgent care setting, but it is something that's officially recommended by the agencies. Next slide. So now I'm going to kind of turn to the impact of point of care testing. And I think that's one of the, another aspect of this. So I'm kind of, before I've been talking more generally about how do you think about these tests overall in terms of managing a patient through their full spectrum of illness. Point of care technology is sort of unique because it's at the point of care, that gives people a very rapid answer and leads to changes now. And I think that point of care technology is something that is getting much more robust. I think COVID-19 has really highlighted the benefit of point of care technology and has made it something that's, moving not just from doctors' offices, urgent cares, and emergency departments, but even into the home. Just over the last couple of weeks, there was a home syphilis test that was approved by the FDA. So there is a lot more interest in using point of care technology, even by the lay public. And I think this is a really good trend, but I think it has to be used. It's not just that they just can't just be FDA approved. They have to actually be used. They have to be part of treatment protocols. They have to be put on formulary. They have to be in places where they can be utilized. Next slide. So I think of point of care testing as a 21st century solution where you can have a near patient test available. And many of these are now CLIA waived, so they don't have to be sent to the lab. And as I said earlier, home tests. So just to name all the home tests we have, because I keep track of this and I've written some papers on it. The first home test was for HIV, and that took about a decade to get through FDA. Then we had home tests for COVID. Now influenza, now syphilis. So it's only increasing, probably coming soon will maybe be RSV, maybe be group A strep, maybe be hepatitis C. Those are things that I think are likely to happen. And then we also even have multi-analyte syndromic testing, for example, respiratory panels that are now CLIA waived. So you can have a box in a doctor's office and an urgent care center that will test for multiple different pathogens. More information, better treatment protocols can be followed, better treatment can be initiated, more epidemiology, more information. Next slide. So when you think about this, it's kind of this whole kind of, so if you think about the stewardship aspect, so what you're talking about with the respiratory viral panel, what you're talking about with a diagnostic test is giving someone a confident ability to not initiate inappropriate antibiotic use and not just hedge their use, because now they've got information that's covering them, that's making them have more peace of mind about it. So if you think about pneumonia, you can think about viral testing coupled to bacterial testing. So someone comes in with pneumonia in an urgent care setting or maybe in an emergency department setting, you test them for, you do the normal things, like, which could include like a urinary pneumococcal antigen, a Legionella antigen, whatever it might be, blood cultures if they're sick enough. And then you're testing if sputum, if they can produce it, but also remembering rhinoviruses are the most common cause of community-acquired pneumonia. Influenza is a major cause of pneumonia. COVID is a major cause of pneumonia. RSV, major cause of pneumonia. All of those things should be part of what you're testing, because then you can say this patient deserves Tamiflu or Paxlovid or antibiotics, or nothing, depending upon what's going on there. And you can do all of this, can all be done. Some of it can be done in an outpatient setting. It's not all going to be inpatient. So group A strep, RSV, influenza, COVID, monotesting, all that can be done in a very, very quickly, and you get a better answer. And then you have clinical pathways so hospitals should start to think about, and urgent care should think about making clinical pathways, incorporating testing use. Say, okay, this person comes in with a URI. These are the things we're going to do. And this is a treatment pathway that we're going to follow, and standardize it to some extent to encourage that use, so that you get better outcomes and you get much more information about what's making your patient sick. And it's not even just like sending it to the public health department. Even if you know in your urgent care, I had 3 patients test positive for flu last week, that influences other doctors. There's been studies looking at group A strep tests that when they start to get positive, if you just write how many were positive the day prior, that influences testing and picks up more cases if you know that it's circulating in the community. So that's another aspect that I think is kind of underappreciated when you think of what knowing this is. That you get the situational awareness in your urgent care about what's circulating in your community just by doing some testing. Next slide. So we are going to be coming into the upcoming respiratory season, and I'm happy to take questions about my predictions for that or the new tools that we have beyond diagnostics. And I think that point of care tests are going to be a critical component to triage people to the correct treatment pathway. The flu season hasn't begun in earnest yet. It likely will start to pick up in October or so. And we're going to have influenza antivirals to be prescribed. We're going to have patients that are admitted to the hospital with influenza, that people are going to present to urgent cares, all settings with influenza. And I think we need to know that they have influenza A, influenza B. And I think that we should try and get better at dealing with respiratory viruses this season, or these post-COVID seasons particularly, because influenza is back, all these other respiratory viruses are back, and then you have to add on top of that COVID. And if you can diagnose people with COVID and you can link them, the high-risk people, to antiviral therapy, you keep them out of the hospital. So a hospital is less burdened by respiratory viruses if you treat them better at the first sign of illness with drugs like Paxlovid, drugs like Tamiflu, drugs like Xofluza, which keep people out of the hospital. So I think of influenza antivirals, COVID antivirals, group A strep antibiotics, and then just overall stewardship. That's going to be really important during the respiratory season, because we will see, as I said, COVID, influenza, RSV, and the rest of them are all going to be increasing soon. And I think we were spared during COVID-19, the other respiratory viruses, because of all of the mitigation measures. That's no longer the case anymore. And I think that we have to prepare for our flu seasons being a little bit worse than what our respiratory virus season being worse than what it was pre-COVID, because there is a new player in the mix, and that's going to add to the influenza, RSV, and other burden that we always have. And I think that patients are becoming increasingly interested in the etiology. Patients, as I said, like to know what they're sick with. And we're in a situation where they like to Google things, they like to read about things, like they may know a lot about what they have. And I think that helps, that gives themselves some peace of mind, and it creates behavior change. If they know they have COVID, they will, even if they're not perfect, they will decrease their social contacts, or they'll tell other people, I have COVID. The same is true for influenza, that I have influenza, I'm not going to go out today, or I'm going to wear a mask, or maybe I'll move this meeting till the next week, and I'm going to tell people that I have influenza, so if they get symptoms, they can get tested. So behavior change does occur, even if we're kind of jaded by what happened during COVID, that many people don't change their behavior. Enough of them do that it's important information to give patients so that they can have that. And, more dramatically, not related to respiratory viruses, but, a person who's diagnosed with HIV, there's data that show that they change their behavior immediately once they know. Obviously, HIV is a disease with much higher consequence than a respiratory virus, but in general, the principle is that when people know what they're sick with, they often will change their behavior to minimize contagion to other individuals. Next slide. So I think urgent care is a nexus where point of care tests have a major impact. You diagnose people with what they have. You can triage them for what level of care might be appropriate for them. Do they need to go to the emergency department? Can they go home? What treatment pathway is appropriate for them? And also for stewardship. There was a lot of effort to get better at antibiotic stewardship in urgent care settings. I don't think it's an easy thing. I can imagine how demanding it can be with patients who think that they need to come out of there with an antibiotic, or they're going across the street to the other urgent care. Those are really challenging things, but I think that point of care testing can help. And as I said, I think urgent care centers are the front line for respiratory virus situational awareness. That's where people are going to present. And there's a major role for epidemiology there of knowing what's making people sick, and then using that and integrating that information, even within your own network of urgent cares, or with the health department, or with local health systems, so that people understand what's going on in the community. You could probably create a weather forecast if all that data was available from urgent care centers and knit together. And I think that's where we're going when it comes to infectious disease situational awareness, is we want to be able to tell people what's spreading in their community so that they can take appropriate actions. And the CDC has made major grants to a lot of different universities to do such a thing. So I think when you think of urgent care, it's where this battle is going to be fought in terms of understanding what's making and getting better at treating respiratory viral respiratory viral infections. Next slide. So some of the barriers are kind of frustrating to me, and this is kind of where we've been kind of stuck. I think that CLIA waived and home infectious disease tests are a major barrier. I mean, a major development, not a barrier, a major development that are not being utilized appropriately, that they're not getting their full bang for their buck, that they're not being used in a way that's most impactful to patient care. They are, I think, the best tool that we've seen. And I always use this picture of Star Trek, where you can see Bones, the doctor there, well, actually Spock is holding it. I think that the tricorder, which is this device that they would use on people there, and it would tell you what you had, what was making you sick. And I think we're at the point where we have tricorders. Rapid point of care diagnostic tests, antigen, molecular, all of the above, are able to now tell people what makes them sick. And we don't have to be in this area where this situation where everything is still biological dark matter, where we don't know what makes people sick and we're satisfied with that. I think COVID-19 should concretize that to people, that having early awareness of what's circulating in a community can prevent some of the bad consequences from happening. I mean, the original sin of the COVID-19 pandemic was we were unable to test. We had no idea who was sick and who wasn't sick. And what happened was these chains of transmissions continued and bubbled over and started to pop up in nursing homes amongst high-risk populations, and then crushed hospitals. That type of thing shouldn't happen if you have aggressive diagnostic testing. And we did not have aggressive diagnostic testing. With COVID, you couldn't do diagnostic testing even even, so for example, in the early days of 2020, South Korea was doing 3,000 tests a day. We were doing like 300 a week. And so it was not surprising what happened with COVID-19 because diagnostic testing was not used. So it's really important to think about diagnostic testing as having this cascading benefit of treating the individual patient in front of you and preventing spread of an infectious disease. And it's the key thing that we need to have in place to make pandemic preparedness kind of much more, to learn the lessons of COVID-19. And I don't think we've learned the lessons, and you can ask me those questions about that in the Q&A. One of the things that I really get annoyed about is what I call balkanization and silo-based thinking. So when you think about all these tests, hospitals and hospital systems, they all fight over it. So for example, in the emergency department, there might be the ability to have a point of care test or really good a test that can be done there. But then the pathology department doesn't want it done there because the pathology department wants to bill for it. They don't want the emergency department to bill for it. So you have the emergency department, the urgent cares, and the pathology department all fighting over who's going to use this test, even if it's CLIA waived and is okay to be used at point of care in an urgent care and emergency department setting. They fight over it, and certain things just don't happen because of those fights, because they don't understand the actual benefit of having it point of care, having it near patient, and it gets very, very frustrating that you're dealing with kind of people who have this siloed thinking that you can't break down. And I would say that that's probably been a barrier to uptake of many good diagnostic tests. I think COVID-19 changed that because there was an urgent need to know what was going on as quickly as possible. So many hospitals basically broke down those silos, but we have to kind of be wary about those silos popping back up again and causing this to be something that creates a barrier to the use of all this great technology that's available in an urgent care and an emergency department setting. And I think hospitals have to think more holistically and realize it's the same organization, that it doesn't really matter so much if it's in the emergency department or the pathology department, and they can't just look at the budget of the pathology department and look at the budget of the emergency department and not integrate those two things, because it's still the same hospital overall bottom line that they're looking at. But oftentimes they all fight over their budget and things like that in a way that makes them almost seem like competitors rather than actually working in the same organization. And that's one thing that I've run into multiple times. And I think that the best way to, as I've said throughout, is the best way to empower physicians, to empower APPs, is to make the correct clinical decision, is to place tools in their hands. I think of these as extensions of your stethoscope. Think of that. Think of Star Trek and Bones and that tricorder. That's what I want to see. That's what the vision I have for people, is being able to do that, to take infectious disease diagnostics to that level of whenever Stardate, whatever that was, in Star Trek. But I think we're getting there, and it's really just about making sure that people are, empowered to use that technology, that they know that it's there, and that they realize how valuable it is to them. Next slide. So that's all I have in the formal part of the talk. I'm happy to take questions on this, on diagnostic testing. I'm happy to take questions on any infectious disease topic that might be bugging you, or a burning question in the remaining 12 minutes that we have. So thanks again for your attention. I hope that was useful. I hope that got you a little bit inspired to bug your administrators to let you use more tests and get you more cool tests so that you can figure out what's making your patients sick, and help make us more resilient to respiratory viruses. So thanks again.
All right. Well, thank you, Dr. Adalja, for that very detailed and comprehensive overview of respiratory disease as well as diagnostic testing, especially as it pertains to the value of obtaining an accurate diagnosis at the point of care. It's clear to me you're a respiratory disease state expert and extremely passionate about all of these topics. And I'm sure I'm not alone in thinking that, so I expect the audience will be rolling in with questions eventually here. But before we dive into our first question, I'd just like to remind anyone on the call that may have joined late, you're able to submit any questions you have for Dr. Adalja through the Zoom chat box on the far right-hand side of your screen there. Just submit any questions you have, and we'll get to them in the order that they're received. But our first question for you, Dr. Adalja, is, and you kind of alluded to many of these points earlier, but it wouldn't be a bad thing to repeat it. But could you share any immediate thoughts or projections that you have about the upcoming 2024 and 2025 U.S. respiratory season? What can and should urgent care healthcare providers be doing now to be better prepared for what's to come in the fall and winter months?
So as I said, it's going to be, a melee of multiple different viruses. And that means flu, COVID, RSV are the big three. So let's take these kind of three things in turn. So COVID-19, right now, we're still at a pretty high level in the United States. It will probably come down a little bit before the winter season starts, but it probably won't completely suppress. And COVID is continuing to evolve to be able to better infect us despite our immunity, despite the immunity from vaccines and prior infections. And the variants that are circulating now, they're called the flirt variants because of the mutations that they have. Those are fairly contagious. So we have to expect that we will see increased COVID-19 cases as it gets colder, as the virus is favored by transmission. And we won't probably get a major lull beforehand, even though I think it's still going to be high, but then it will probably it'll come down a little bit and then go back up as we get into winter. And I think what you want to be able to do is utilize the antivirals that we have for COVID, which means you have to know that people have COVID within 5 days. That means you've got to be aggressive with testing for COVID. But COVID overlaps completely. You can't tell COVID from influenza or from RSV or even from strep throat sometimes. So you need to use those diagnostic tests to put people on the right treatment pathways. So we expect RSV to increase as well as influenza, and we want to use the influenza antivirals as well optimally, just like we want to use Paxlovid optimally. So I think you have to be prepared at an urgent care center to make sure you have the ability to differentiate these infectious diseases from each other because they have different treatment pathways, and they're all going to be present at the same time. So I would make sure that you have the ability to do that in your urgent care center, and your urgent care providers are familiar with antiviral pathways. Like I said, I would make little placards or little note cards or something and stick them on the wall so people know the pathways for, this is what we're going to do. If someone has a respiratory virus, we're going to test for flu, COVID, RSV, group A strep maybe. And then if they've got COVID, this is the pathway. If they've got flu, this is the pathway. RSV, the pathway, and group A strep. So that needs to be something that people are proactively doing now so that they can be prepared.
Wonderful. Thank you. Great information. So the next question here, a little bit of a curveball for you, but what are your thoughts on avian influenza and everything you've been hearing about the recent outbreaks occurring across the country in farm animals? Is this something we should be concerned about, given your experience working in pandemic-related disease states?
So that's a great question. Avian influenza is one of my favorite topics to talk about. So I've got to limit my comments so I don't give another hour lecture. But I think that's the biggest pandemic threat that we face. And what's happened is, we've had H5N1 influenza A circulating since 1997, but really in a major outbreak over the last couple of years that's been decimating poultry farms all across the United States and as well as around the world. What's new is that this particular clade or strain of H5N1 has been infecting more and more mammalian species. And that's a big step. Remember, birds are not mammals, so things can infect birds, but not infect mammals, and we're mammals too. So that's why there's a big alarm. And what happened is it started to infect marine mammals like seals. We've seen it infect cats. We've seen it infect bears. And what really changed was it started to infect cattle. And it wasn't making cattle sick with respiratory illness. It was making them decrease their milk production. And what we found now is that this is pretty widespread. Starting in Texas was the first case, but now 14 different states. The most recent is California, which just confirmed it in 2 different herds, that this virus has now gotten into cattle. It's likely spreading via, it's dairy cattle. So it's the milking process and the movement of cattle between different states. So the California strain is the same as the Colorado strain, which means they probably moved a cow from Colorado to California. That's been very concerning. There have been a handful of human infections. They've all been mild. A lot of them have had conjunctivitis, not standard respiratory viral symptoms, and they haven't had severe disease, although we have had people with H5N1 in the past that have had fulminant deadly disease. I don't think that the cow outbreak itself poses a major threat to humans unless you work on a dairy farm and a poultry farm. And what's really been the issue here is that many poultry farms don't want to test. And there's been a lot of bureaucratic hiccups between the USDA, the FDA, the CDC, and the state departments of agriculture and the state departments of public health. And there is a lot of this see no evil, hear no evil. It's definitely more than 14 states. I would just tell you that map you look at, many states are not testing, willfully not testing. And that's the wrong way to go about it. They're not testing their cattle and they're not testing their workers who have come down with respiratory symptoms. So that is a perfect recipe for something bad to happen. But that's because people think of these cattle as an economic commodity, and there's a lot of stigmatization if a farm is found to have infected cattle, and that's kind of hampering our ability to get full awareness of what's going on. I don't think that this virus is going to cause a pandemic in humans. However, there will be an avian influenza virus that causes a pandemic, and we should think of this as a trial run, and we're failing at the federal level and at the state level to actually get our hands around what's going on these cattle farms. And I think that this virus is more forgiving, but there's going to be one that's not. So if we can't get it right this time, I really worry about what will happen when there's a more dangerous avian flu virus that circulates in the United States.
Thank you for that in-depth explanation. And our final question for today, because we're almost at the hour. I appreciate the speed and rapid turnaround time that antigen tests provide. But Dr. Adalja, how can I improve the performance and reliability of antigen test results, given its reduced sensitivity in comparison to PCR?
So I think you have to think about what you're asking the test what you're asking from the test. When someone is sick, the antigen test is a good first line. It's going to tell a positive on an antigen test, you're done. You've got the answer. You can move that patient to Tamiflu or Paxlovid or whatever it might be. If it's negative, you have to kind of think, did you get a good sample? Where are you in the illness? How sick is this patient? Do you need to do another type of test? And I think that depends on if you've gotten an answer of what's making my patient sick with the antigen test, and that definitely when you're using multiple antigen tests, like a test that tests for flu, COVID, and RSV at the same time, or something like that, you're doing them all together. And you don't have an answer. I tend to think especially in any high risk condition, if they're going to be admitted, I then will couple that to more to PCR testing. But for first line, antigen testing, I think, is invaluable because of the speed and rapidity. But you have to then take a step back and look at the patient in front of you and say, do I have an answer for what's making this patient sick? Am I satisfied that I don't need to do something different for treatment? Is this patient sick enough to need hospitalization? Then I think you need to do more. But I always think that antigen testing, first line, can really cut that process off if it's positive. And many of the antigen tests are sensitive enough to be able to, I'm not so much worried about their sensitivity. What I'm worried about is they don't get used enough. And I think that the second part of using a PCR as a backup in certain cases makes sense. But in general, I think that the sensitivity when someone is sick is fairly decent. But just remember, if you're testing for COVID and it's negative, that doesn't mean that you're done. They could have influenza, they could have RSV, they could have other respiratory viruses. So just remember that the antigen, don't fault the antigen test if you didn't, the antigen test isn't testing for everything. In terms of what could be making that patient sick. And the other point about antigen testing is if it's negative, at least you know that they're not contagious for COVID. If a person is antigen negative for COVID, they're unlikely to be contagious. If they're antigen negative for influenza, unlikely to be contagious for those viruses. So you can also use antigen tests as a contagiousness test. But I think that their value is really outweighed in terms of the rapidity and ease of use as a first line test. And again, just step back and think about the patient in front of you and decide what other testing might be necessary, especially if they're going to be hospitalized or have a risk factor for severe disease.
Interesting and great points, Dr. Adalja. Yes, I've heard the antigen testing being a solid precursor for identifying infectiousness. So that was a great point you made. But we appreciate you for all your time and insights on these relevant topics as we rapidly approach this year's upcoming respiratory season. I think these are timely topics that we covered today. We don't seem to be getting any further questions in from the audience, and we're close to the hour, so I think it's time for us to wrap this up. Also, a big thank you to everyone in the audience who took time to join today's session. We recognize many of you are very busy and important people, so we Sincerely appreciate your time and attention and hope you have a great rest of your Thursday. Thank you, everyone.